Hello, and welcome to Reed Scholars Live. I am your host, Mary Fleming, and current president of Reed Scholars. Today, we are joined by Dr. Wilson Wang. Dr. Wilson Wang is currently a practicing pediatric hospitalist as well as an adjunct professor in the College of Global Public Health at NYU in New York City. In 2018, Dr. Wang founded Walking Doctors, a company that works to decrease medical errors in low and middle income countries. Dr. Wang received his MPH from UC Berkeley, his medical degree from UC Davis, and completed his residency in pediatrics at Children's Hospital of Oakland. Dr. Wang is also a Reed Scholar and received his MPA from the Kennedy School of Government as part of the California Endowment Scholars in Health Policy at Harvard. Dr. Wang has an extensive global health and policy experience working in Liberia and Rwanda, as well as with New York City's Department of Health and as a legislative assistant in Washington, D.C. Dr. Wang believes that the health of populations is mostly about communities having access to resources and the ability to modulate the kind, tender, and distribution of these resources. That was a lot, Dr. Wilson Wang. We appreciate all your hard work over the years, and we appreciate you joining us today. How are you?
Doing well, thank you. It feels like a Friday, but it's a Thursday. But I think during this time, there is really no sort of time marker. So it's just great to be here, whatever time it is, whatever day it is.
Definitely. All the days do seem to run together. It's like, is it Tuesday? Oh, no, it's Saturday. Who knows? But here we are. And tell us what's going on with you. You're in New York. How are things? Has life changed for you over the past few weeks, few months?
Yeah, I think I'm like everyone. Life is totally the same and totally different, right? The paradox of this existence of ours. I mean, it's the same in that I'm still a doctor. I still have a family. We're still healthy, thankfully. New York City, if you're not in the hospital and not, then, blind to the fact that everyone's wearing a mask is kind of the same, right? You still can bike to work. You can't play basketball anymore, but you could, go for a walk or, spend time with family. But it's different, right? You mentioned that I do international work, and I can't travel. In fact, today I was supposed to go to Indonesia. Not totally bummed about that, and that I know, my privilege and still being able to chart, a course, even though it's a little bit different. I'm a pediatrician, so I want to really just pay accolades to the internists and adult doctors like yourself who have really borne the brunt of the epidemic with their patients. With pediatrics, even though, there's really some unique pieces of this, like there's this hyperinflammatory state of kids, blah, 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 but they just have not borne the brunt of the disease. It's mostly old people with chronic illness, a lot of minorities, and that's good in one way because I've been able to sort of extricate myself and act like a manager, a policy, or a leader, and not get totally crushed because I know what that's like. So I just really did want to clarify what I do and don't do, but also really pay homage, especially to patients and their families, who are really confused and scared, and of course their providers who help them become less scared and confused.
Definitely. Everybody is readjusting to this new normal, and we're all trying to find out where our new place is to help, make this as best an experience as possible in the face of so many adversities. Speaking about being a pediatrician, and you've done a lot of clinical work over the years, but you also have a great amount of experience outside of the clinical world, right? And so this is going to be part of our digital health and health equity series. And so I wanted to spend a little bit of time talking about how you got interested in the technology aspect of medicine and what that transition was like for you. Was that something you'd always been interested in and it was a natural transition, or did you see a gap or identify something that was lacking in the medical field and wanted to transition into technology?
Yeah, I'm not techie at all. I mean, I have an iPhone, but I'm of the generation of like Atari. I typed my essays in college. So it wasn't a natural transition, but I think one thing that I've been lucky about in my life is just to respond to feedback. The short story is that I worked for between 6 and 7 years in Rwanda, Indonesia, and Liberia in support of healthcare systems within large NGOs. That just meant that I helped hospitals, emergency operations, and clinics run in a way that I wasn't trained. So like staffing, bringing in, hundreds of thousands of dollars, millions of dollars in medicine, making sure that staff are paid, and trying to do that in an elegant way because I was a foreigner. I wasn't,
Mm,
working. I wasn't, in those countries. I was assisting. Um, but I had a great mentor who told me, like, if you're going to be a doctor, please you have to be a doctor. So don't just drop it.
mm,
So in order to do my job well, I essentially volunteered every Saturday for 7 years, even though it wasn't part of my job description. I worked in the health facilities that I was supporting.
mm,
And in that process, I saw very immediately what was the problem. Like, you could order a medicine, if it doesn't come, okay, then you have problems with medicines. Or, oh, I want to write something down. Oh, there is no medical chart.
right.
Oh, I would love to, put this IV in, but there are no nurses. Oh, the doctors didn't come to work that day. So very quickly, I saw that the nuts and bolts of what I, presumed would be the basics of a system weren't in many of the places that I uh, uh, was assigned. And I basically just experimented with what worked. And, what works in any situation works abroad. And that is, you have to make clear what is the task at hand and then hold people responsible to that task.
Mm,
So the task at hand, just from a managerial perspective, and even as an individual provider, could be drastically simplified through checklists, right? So even
right.
I, with my vast experience, right, I forget the dose of amoxicillin, which is a shame since I'm a pediatrician, right? It's just like, or the other day, here in the United States, I had someone with, anaphylaxis, and I forgot, which type of epinephrine was it? Was it the 1/10,000 or 1/1,000? Was it zero point 0.01 or zero point 0.1? You just forget these things, especially if they're kids and there's dose related. So things could be simplified drastically, especially since most providers in the world aren't aren't doctors. So, and then because things were placed on a series of checklists, then you could manage much more clearly. You could run the numbers.
Mm,
So fast forward maybe 2, 3, 4 years of this and showing that, oh, geez, checklists work. Um, I found that technology was a way to synthesize all these checklists into a single platform, and we used the use the medical record as a vehicle, since most people would
mm,
acknowledge the medical record, an electronic medical record is inevitable. So we sort of put those things together. Technology was the way to go, and thus I developed a company to take advantage of this sort of dual, providers need support, but how would they best get that support from a structural level that would be electronically through technology?
that makes sense. And I don't have as much international experience as you have, but I spent a couple years ago. I spent about 6 months in Kenya, and we were, I mean, very far off the beaten path. But they did have an electronic medical record. And so when I was kind of telling the story about that when I came back, it's like, well, there's infrastructure there that allows there to be technology to bridge some of these gaps, even if you don't have the other things. So it allows you, like you said, to use, even if you have limited resources, you can use those limited resources so much better if you have some guiding principles. And one of the vehicles for that is an electronic medical record. So that's pretty exciting. So tell us, a little bit more about the physical or logistical part of starting a company in that space. Did you have to teach yourself some business principles? Did you have to, about networking and partnership and actually entering that field? You don't have to go through the whole thing, but I think as far as when some of us are trying to transition into different spaces, it's good to kind of know that story on how you do the workarounds.
Sure, sure. Well, let me just qualify that even though I'll describe this as an ultimate success story, by most measures, I am not a success because, my company is not self-sustaining yet. I mean, self-sustaining, I sustain it, but it doesn't have a lot of customers yet. It
Yeah.
doesn't,
But you're
it's not
new.
in
It's only been a couple
yeah,
of years, Wilson. I
yeah,
think,
no,
you
yeah,
don't go from 0 to 60. I mean, come
yeah,
on.
no, I'm very proud of it, but I don't want to make it sound like, I'm epic 3 or something like that. So, I think one thing that I learned very quickly, and I stick with it, which has made this process not as hard as I thought it would be, given the fact that we still have much room to grow and to succeed, is that if you start something, you have to really diagnose the problem and come up with the treatment correctly. In other words, I know that this approach works, right? And I know that I know it works starting with myself. A lot of time when you do international work, especially as it involves technology or including technology, people come up with things that they think it would work for someone else when they sort of paradoxically or hypocritically sometimes wouldn't acknowledge that it's not really that good of an idea. An example of that is there's a lot of health messaging that goes on in international health, like, oh, if your baby is vomiting and cold, please bring that child into care. I mean, I don't know how many parents in the world wouldn't do that naturally without a text message from some foreigner. So there's that piece. But I know as a provider, and especially since when I was taking care of or helped lead teams of providers who usually were not doctors, they just did not have intellectual backstop, right? They, first of all, in a lot of places, they never had a library. So how often are you going to look something up, even if you have access to internet, because you never had practice of looking things up? But the second thing is like, where do you even start, right? We know how busy it is to be a provider. You don't just like look up stuff. Even here in the United States, we have UpToDate. It's great when you sort of use it, but not that much actually, because it's not really part of our workflow. So I understood very early on that there are no bad intentions, of individuals. There's really just bad systems, and the system hasn't been set up to adequately support physicians, especially abroad, but even in the United States, right? How often do we providers, we're documenting over 50% of our time, but we're not really being helped with regards to our decision making. So that's one side. And the other side is because I had the privilege of being able to support systems and not just be an individual physician, I needed data. And I found that I could not get the data for quality improvement, for research, for public health purposes, if I didn't elucidate what was happening at the provider patient level. So once that could happen, then our whole system could happen. So that's point number one, that if you have an idea, just go with it. If it makes sense that, people are waiting too long for taxis in New York, or why can't, someone come by faster? Okay, here comes Lyft and Uber, right? That works. I think the other piece too is to get help, right? It's like, I don't know how to start a business, right? So you join these pitch events, and through these pitch events, I found people who actually work with me still in the company. I got $50,000 just by talking about the business at a sake tasting party, and I only remember half of that party. And so you never know, who is going to help you, but if you have an idea that's solid and you're willing to take in feedback, and I think maybe the third piece is to put in your skin, right? So for me, people said, "Oh, you never should invest your own money into your business." I'm like, what are you talking about? I would think I should be the first person to invest it, so people understand that it's not just their risk. So I also related to that, realized that if my own mother or father wouldn't invest in what I was doing, why would a stranger? So it took my father like 3 years, but my mother was on board like pretty much in day one. And so our family has, we call it bootstrapped the company to this point. About, we're privileged, so it's been about $200,000 over 3 years. So yeah, I think I would summarize it in that way. If you have an idea that you believe in, you can grow with it, right? It's sort of like I think this is what painters might feel, right? They're not sure exactly what the painting will be, but they have the idea, they care about it, they're watching it develop on the canvas, and then people are feeding back like, oh, that painting is shoddy, or no, go beyond the lines, stay in the lines. And then and being willing to accept that feedback, and then being willing to plow your own resources and time into it. So I've worked for 3 years, and I've never paid myself to do it. Not only do I not have money to do that, but I need to devote the resources available to other people for the things that I cannot do.
That makes a lot of sense. Well, thank you for sharing that part. I think I like to know the behind the scenes things, so I think that would that helps others. I want to shift a little bit and talk about a little bit about more about the health equity piece. And I have two separate questions. So one is about increasing access, and one is about making sure we don't increase barriers when we talk about digital health platforms. And so with your platform specifically, I know yours is mostly geared for global communities, but I'm sure that it could be useful here as well. But, and correct me if I'm wrong, I think part of the checklist is making sure that we're treating everybody the same and making sure we're not missing anything. So not just the correct diagnosis for that patient, but the correct diagnosis for as many patients as possible, right? So that should improve equity in that context. So I just wanted to know if that was purposeful, which I think I know the answer on your part, or and how that thought process went and making sure that was part of the goal.
Sure. I mean, certainly, starting with the fellowship, the idea of equitable treatment is forefront on my and the fellows' minds, graduate fellows' minds. It is sometimes interesting to talk about health equity in places like Liberia or rural Indonesia when the majority just became our minority, or whatever the flip is. Like, there's always sections, but you go to a place like Liberia, and my studies showed that errors in care approach 40 to 80%.
Jeez.
Right? So while there are certainly, it's really important not to conflate the fact that you increase the general care of the population, you improve minority care. Well, that's true, but it still is not the only issue, right? There are others, so there are layers. But I think a good place to start, especially when things are so extreme, is to improve the general care. If you can improve the general care, and you can improve it in a way that is auditable, then you can see what are the details within it. So in our system, you're right. As soon as the physician or the healthcare provider, who's usually not a physician, just keep in mind, there's one doctor per 350 in the United States. In Liberia, it's 1 per 20,000, right? So you have to work with the providers at hand, and not think that the doctors are coming anytime soon. So the healthcare provider, after hearing the story and doing the exam, right, comes up with what they think is the diagnosis. So in our system, they pull up the checklist associated with the diagnosis. If they're not sure, they could look up something like chest pain, and the system will give an idea based on a few tests what it probably thinks it is, right? But you do have to be somewhat skilled. It's not like, you lay back and the system just works by itself. It's for health professionals. So once the checklist appears, it then says, like, if you're going to make the diagnosis and treatment correct, you have to have the following components. And it gives you feedback if you did or did not meet those components. Now, some people would say, well, why would any physician be so crazy as to use this stupid checklist system? Well, the checklist system is very respectful. First of all, it says, hey, I'm going to help you. I'm going to help you write your note. I'm going to help you come up with the dosing so you don't have to look it up. I'm going to help you come up with the reports if that's in your job description. The other thing is that if there's 4 different medicines to give, it lists all 4 and it lets you decide what you want to give. And lastly, you can proceed without it. Just write a note within a blank square. So, but people like that if you're respectful and you're saving them time. People want to do the right thing. So it really does help standardize care. So we have very nice graphics. We call them dashboards, right? Real dashboards like a car, where you could see across the system, what are your top 20 diagnoses? How are you doing with regards to diagnosis, treatment, and patient education protocols of those diagnoses? And then you could cut the data in terms of age, gender. We haven't done it in terms of ethnicity yet because, frankly, as a foreigner, it's very difficult for me to understand what are the ethnicities when these large majorities, when again, the situation is really quite bad generally. But without data to decide where are the gaps, there can be no progress in general quality, but especially in quality that affects the minorities.
That makes a lot of sense. And then in thinking about here, so shifting again, I think because of the ongoing, I was going to say recent pandemic, but it's ongoing, right? The ongoing pandemic.
Yeah.
We're thinking about digital health in a different way. So we've had electronic medical records here for, since I've been in training, so a while. We've had some type of, artificial intelligence, right, and decision-making capacities in some of the EHRs here. I think the thing that's happening more now, as far as and that's mostly physician facing or healthcare provider facing, but for the patients now and their interaction with digital health is more about, now we have apps on our phones and reminder alerts from our my chart or whatever the derivation for your EHR is. And now we're experiencing these telehealth visits and transitioning from the telephone calls to the video chats. And so, a big question a lot of people are talking about is do the people who are still in these vulnerable populations have enough access to technology and enough technological literacy, if you will, to be able to access those things in a fair and equitable way, and so that we're not introducing barriers by trying to improve access or provide access, not even improve in some cases in this type of situation. So any thoughts? I know that's not exactly what we were talking about, but any thoughts about that?
Sure. I think there's a lot of opportunities, right? Hopefully this is like one of those character building moments for a country, right? When challenge and overcoming adversity leads to the right lesson, right? There are always the possibility that leads to the wrong lesson, but let's give it the benefit of the doubt, right? So one lesson certainly is the idea that telehealth has a role, right? If access is an issue, certainly people have seen that you can use modern technology, easily readily available technology, to provide that access. And I think that's great, right? But I think we have to realize that if there are such great disparities in healthcare quality for minorities in the United States when there's a face-to-face, how actually does that get degraded? So I think it's a good time to differentiate very succinctly what is the difference between quality and access. So whereas you could increase access, there remains the quality issue, which will not be dealt with telehealth, because if anything, it takes away a dimension, right? That's why, going back to my company, it's been so fun to basically learn from our experience with regards to electronic medical records. I mean, what is the gap right now with regards to the epidemic, which has made this really a horror story for this country relative to the world? We're the top in everything. Like we always say, we're the top. We are the top, right? Even for this different category. We don't have a connection between what is happening in the hospital, in the clinic, what we do as providers, and what public health bodies need to make decisions with regards to population health, right? So we still don't know, like, presentation symptoms of certain age groups, different ethnic groups, their fates, the connection between individuals' test results and where they end up going, right? Right now, the public health bodies, they literally call right, for test results, or they plea in terms of asking healthcare providers to enter into very cumbersome databases
Right.
what they are seeing. So without ability to say like, hey, there's a hotspot over there. Oh, hey, this group is not doing well over here. Oh, this cohort is doing totally different things. What does that mean, right? If you can't answer that question, then I don't think you can control an epidemic, and therefore we do not have control. Everything is voluntary. Every health facility's healthcare data is by and large their own, with no obligation to share it. And I'm not trying to be cynical. I'm just trying to say we have very rich data, but there's a reason why we have not been able to know where this is, where it's going, and how we're going to do, because we don't have the connection between healthcare facility data and public health data.
Yeah, I think, I mean, of course, this pandemic has highlighted a lot of disparities and inequities, but I think it also has shined a light on the fragmentation of our system, right? So our system is great in pieces, but I mean, this is not new. We've never really worked well together. And so hopefully, we'll do better going forward, but we'll see. Um, so, kind of as we come to a close, I wanted to ask a couple more questions. One, and you've touched on it a little bit, but kind of being optimistic, right? So we've shined on, the downsides, but what do you hope we'll see? What are the opportunities going forward after COVID and for digital health and the digital health space, especially as it relates to health equity? And then my last question, so you can think about them both at the same time, is what type of advice would you give anybody who's listening who is in health in a broad sense, who is interested in moving into realms and possibly being more involved in the technology space?
Sure. Remember, I'm getting older in my years, so I might
I'll
have to
remind
ask
you.
you to remind me the exact question. Let me take the last question first, because I actually remember it the freshest, and that is, younger generations, and if you want to, split out your career, do it if you want it, and don't if you don't. But if anything, the MD by your name, your personal interest in health care of uh, resource poor populations, minorities, that opens up so many doors. And sometimes it's just the idea and aspiration and the motivation that something needs to be done. Reason why I love doing international health, and frankly why I love working in Harlem, where I'm right now, is that you cannot escape the problems. The problems is staring at you in the face. Just a very quick example. Yesterday, I was seeing a 69-year-old man, which is strange for a pediatrician, but these are weird times. And so I basically I volunteered to see Fast Track for adults, right? Because the core adults, they're all in PPE and really scary looking, and sometimes have really sick patients. So I said, okay, come on. We adults are just big babies. So I saw this man who had hemiplegia from a stroke. We don't have that really that often in kids. And so basically he's doing okay, but he has right side hemiplegia, so he puts a lot of weight on his left side and develops these really serious like calluses. But he can't move his right side, and he lives alone. And so he had to come in to have someone trim the calluses, but every ED, and he'd been there twice before, he always referred to podiatry, and they're not open. They're not open.
Oh my goodness, right.
So I'm sitting there, a pediatrician, looking at this guy with the hugest calluses and bunions I've ever seen in my life. I didn't even know they exist, because babies don't have bunions. I'm like, give me that X-Acto knife. How hard is this to do, right? And you can do it, right? That's sort of like international medicine. If people ever ask like what's international medicine, just think about our epidemic or pandemic here. It's exactly the same. People like to think like, oh no, 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 no. No, it's just like it. It's like there are things that are normal and there are things that are really, abnormal. So I think, I look at my career trajectory as certainly like a privileged plate of food, and that food necessarily must have different textures and different colors and different makeups, right? So I look at, the reach to, health technology or just some other endeavor, which inevitably will employ health technology, is really just adding richness to, to this life, and hopefully, that ability to take from different food groups and to take from to learn different things enables me, to be, to be more impactful. So let me go to your first question, and please redirect me
Yeah,
if I got it wrong.
you're doing
It's
perfect.
going to be what are the opportunities, I think, for minority populations,
On the
relative
other
to
side.
this pandemic? Yeah, I mean, I think most of all, it teaches us that health inevitably is not found in the healthcare facility.
Yes.
We notice that, even though a ton of money, has gone, you know, to the healthcare system, and understandably so, when you can't do basic public health 101, right? And the spigot is now loose, the waters are moving or flooded. The virus is airborne. Not airborne, is whatever, spread through, is in the air. That you 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 have to realize that the people that have suffered most from this illness are not those that didn't have access to healthcare per se, but were those people who were poor, those people that, because of options for living and eating, were obese, who have chronic illness. There's this amazing statistic in New York City. That's where I am right now. If you look at the whole country, it might be rising, but at least like 3 weeks ago, I think 2 doctors unfortunately had died in the response in the United States. But as of 2-3 weeks ago, there have been over 45 MTA deaths, like of the workers
Oh,
that
wow.
work in the subway, in the buses, right?
Yeah.
I mean, how does that go? Well, I'm not an expert in MTA workers, but I know it's sort of played out socioeconomically. So I think we learned that we have to use the privilege of the titles next to our name to realize that, sure, we must use our skill to to aid those with acute illness, but we also have to use our health hats and health credibility to take a step back and help society reframe what is the problem to begin with. So certainly one problem was just public health response. Like, I'm Taiwanese American, so I was always proud to be Taiwanese, but look at Taiwanese response. It's crazy.
Yeah.
They're 80 miles off the coast. They've had 7 deaths.
Yeah.
7.
Amazing.
7. I mean, this country is averaging 100,000. 7, right? It's not, it's not Singapore either. It's just like they identified really early that this could be something really severe. They activated certain response. They've done real quarantines. They've done really real tracking, etc. So, we have to realize it's always better to do prevention, right?
Yes.
And then the second part is to realize, the stat I looked at was so impressive, is 10% of all human health is determined by healthcare, right?
Mm-hmm.
So given that, why do we spend 90% on healthcare? Again, I'm not trying to unemploy myself, and my job, I make my living as a doctor, and also to advance an electronic medical record. But much of my life is also about figuring out what's the most efficient way to do that. So that's data with the EMR, whatever. So I think that's one big lesson, and I hope we learn it. I'm not sure we are, because the people that know it aren't the ones that get to decide. And the
Mm,
people that could learn it, they're too busy, doing something else apparently. So, I think there's opportunities, and certainly we have very, really respectful, awesome people in the fellowship that can really just remind people that we must have good health care. If anything, just even not to waste our money on healthcare that's inefficient or ineffective. But we have to just remember, like, I have great health insurance plan, but that's probably not the reason why I've never been admitted to the hospital.
right.
Right? It's related to a lot of other things.
And that makes a lot of sense. And I think, as we move forward, and well, looking at this general sense situation, is that it's giving us a lot of opportunity for creativity and innovation, right? And so, one of the things that I was excited about talking about you is even before this, you were thinking about, where are the gaps? How can we be innovative? And how can these innovations help the most people? And I think that's a huge takeaway from this situation, from all the work that you've done across the world. So thank you so much for talking with us and sharing your story and your insights. And I'm always excited to talk to you. I learned a lot as always, and just appreciate you giving us a little time today.
Well, thank you, Mary. Such a awesome that you're doing this activity. I think you're engaging in an activity that many of us didn't even think of, and it's just even following this 30-minute time together, I almost feel like I've seen a therapist or something. So it's really nice to share too, right?
Yeah,
During this time, it's really important to have those avenues for sharing and learning. So thank you very much.
definitely, definitely. Well, thank you so much. Good to see you, and take care.
To see you. Bye.
Thank you for listening to Reed Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our